So I'm here to talk about assessment tools for MTSS. So generally we're going to use the method of symmetry, range of movement, tenderness on palpation and special tests when you're assessing a client. So it's called an ARTS acronym, ARTS. So the first thing we're going to have a look at is a symmetry. Ideally you want to have a look at the way your client walks in through the door. You're having a look at their true representation of gait that way, as opposed to getting them just walking up and down the clinic. Sometimes they may consciously change the way they're walking purely because they're aware that they're being watched. So what you're looking for when you are assessing their gait is you're looking for possibly a little bit of a Trendelenburg. So the Trendelenburg is the swaying of the hips. It's a little bit of instability within the femur, so inhibited glutes, possibly tight adductors. It's also Q angle issues, so it's quite common in women to have a little bit of a Trendelenburg. You're definitely looking for the swaying of the hips there. You're also having a look to see whether they might have a bit of an antalgic gait, so a limp, basically, a painful walk. They might have a bit of an arthrogenic gait, a little bit of a circling or swinging with the leg, just indicating a bit more of a joint issue there, or pain. So definitely have a look at the way they're walking. Also looking at the actual ankle joint, looking to see whether it's pronating, any tibial rotation when they're walking, whether internally or externally. So there's a fair lot to have a look at there. Then you want to have a look at their static posture. And you always want to have a look at the joints. This is the ankle joint really we're assessing on the lower limbs. So you want to have a look at the ankle joint, the knee joint, possibly even the hip and pelvis as well, as it's just the whole lower limb, to be honest. So you want to have a look at the symmetry. So the 2A AIS points, indicating possibly a bit of a lateral or anterior posterior tilt or rotation, whatever you want to call it. You want to have a look at the knee joint to see whether you've got any genu valgus or varus. So valgus is not knee, varus is bow-legged, so they only want dysfunction through there. Then you want to have a look at the tibia and seeing whether the tibia is rotated in relation to the position of the femur. So if the femurs look like they're pointing forwards, the patella looks like they're pointing forwards, but yet the feet are pointing outwards, that's what you call a lateral tibial torsion. So you're having a look at the asymmetry there of the lower leg in relation to the femur, relative to the femur above. Then you want to have a look at any whether the calcaneus here, whether that is externally or internally rotated. So with pronation it's normally externally rotated, so it's coming outwards because you've got a little bit of a drop through this medial part of the ankle joint. So you're looking to see whether that's the case. You're having a look to see whether the foot has got this lovely arch, which it should do, or whether it's quite flat, pes planus, or quite arched up for pes cavis. So we're having a look at quite a lot of stuff in that static posture to try and identify the possible causes for this MTSS problem. You're going to definitely have a look at functional tests. Two of my favourite really are squats and single leg squats. So squatting, you just have a look at the client's ability to squat or do that movement pain-free. You also have a look to see whether there's difference from one side to the other. Can they dorsiflex on one side more than the other side? Is one side painful, the other side not? Is the knee coming in on one side? Are they perhaps leaning to one side when they're squatting? It's a wonderful functional test. Also with MTSS, a single leg squat would be wonderful. So standing on one leg, again having a look to see whether they can engage through the glutes to stabilise themselves in one-legged activity. We run on one leg after all. Then you want to get them just moving and bending the knee, squatting down slightly. It doesn't have to be all the way. Looking again to see whether they can stabilise the femur, so whether you've got that genu valgus coming in, whether you've got that pronation, that external rotation of the calcaneus, the internal rotation of the tibia. So you're looking for all sorts of things when you're doing functional testing. With MTSS as well, because it is a lower limb problem, you might find that hopping or calf raising or something like that might be quite useful. You might be able to recreate some of the client's pain. So this is a diagram basically, and this is what we're going to be looking for. So you might find that you've got the overpronation, as you can see there. You might find you've got the internal tibial rotation. This is more probably through movement dynamic testing than your static postures. You might find that the internal tibial rotation, as you can see there, you also get sometimes femoral internal rotation relative to the tibial internal rotation. You can have a look at greater trochanter heights and you might find that they're not quite level. ASISs, anterior superior iliac spines, you might find you've got a bit of a unilateral lateral tilt to your, or inferior tilt to the pelvis. So you'll see a lot, I should imagine. So starting with the foot, you'll see a fairly flatter foot on that side, pes planus. You'll see pronation or external rotation of the calcaneus. You'll see internal rotation of the tibia and relative internal rotation of the femur. You'll see probably a little bit of a lower inferior greater trochanter because of that, and then a dropped pelvis on that side as well. So you'll see a fair lot. Okay, so keep an eye out. We move then on to ranges of movement. Generally with MTSS, all ranges of movement are going to be okay. So when you're doing your passive testing for length of a muscle and pain, and when you're doing resistive testing for your strength of a muscle and pain, generally all will be okay, because MTSS is characteristically more of a kind of a bony periostis problem, or where the muscles attach into that periosteum, medial soleus being the particular main one. Really than a muscular issue. So generally they'll all be negative unless there's compensatory or secondary problems going on as a consequence. Palpation, tenderness on palpation. So where you've got pain is this medial tibial border here, generally posteriorly, so a little bit more around the back. But it's this lower third is where you're going to get pain. Okay, so this is the area where you're going to be looking for, as you can see also on the diagram. What you also might find is that the pain area might feel quite lumpy and bumpy under your touch. Okay, so chronic kind of inflammatory issues have been going on there. So just have a feel around for that. So lumps and bumps, and obviously pain, definitely around this posterior periosteum area of that medial soleus attachment. What you might find as well, when chatting to a client, they might complain of a lot of referred pain around the back of the tibia into the muscles. Sometimes you might even see some diffuse swelling as well. Not in all cases, but something to keep an eye out. So when you're doing your palpation, you're feeling, but also you're obviously looking as well. Okay. Generally what happens with assessments for MTSS, you have a bone density scan. If you feel that you need to confirm this against a stress fracture, for example, you would send them off for a bone density scan, and it will just help to identify perhaps if there was any periostis, any inflammation of the periosteum, particularly around that kind of fascial muscle attachment posteriorly on that medial tibial border. Okay. Otherwise, MRIs could be used, increasingly so they are at the moment. They help to identify any bone marrow edema, which could indicate that there is a little bit of MTSS reaction, a bit of a stress reaction going on, or it might even show some thickening of that periosteum as well. So either scans will help to identify that MTSS has occurred. In terms of differential diagnosis though, because you've got pain on this medial tibial border, so it could be stress fracture, it could be anterior compartment syndrome, it could be an anterior muscle strain, tibialis anterior muscle strain for example, or it could even be chronic compartment syndrome. So how do we know the difference? So I would imagine that your client's going to run a 5-mile run. With a stress fracture, they're going to have pain when they first start the run, and then the pain will just keep on going, and they'll probably have to stop that run. Okay? With MTSS, they start running, but the pain will go after they've warmed up. So after the first mile, but for the rest 4, they can continue, and it's not really a problem. They get more pain after exercise and first thing in the morning, as described previously. If it's chronic compartment syndrome, generally the pain again won't be there initially, but will actually come on 10 to 15 minutes into the activity. So unlike MTSS, it comes on but then goes. This comes on after, let's say, that first mile, and then stays there. If it's an MTJ problem, so musculotendinous junction strain, possibly, or mid-belly muscle strain in that tibialis anterior, more commonly MTJ, then it kind of depends really on the severity of the strain and the exercise that you're doing, but generally it might get better as you get warmer, but also it might get worse. It kind of depends on the severity. But with that, the pain is very localised around that MTJ slot of that, which is located around this area of that tibia. But you'll probably on palpation feel a bit of separation of tissue, so your palpation skills come into their really own play here in order to distinguish between the two. But imagine that 5-mile run, and that will help you make your diagnosis. Thank you.